Yes, okay.
Recording in progress.
Okay.
Okay, thank you. Thank you, Poonam. I welcome you all for the first webinar of this session, 2025-26. I, as President, welcome you all in this webinar. And our speaker is esteemed Professor Dr. Vasudevan. And we will have case discussions followed by that. Now I invite Jeejesh to take over the proceedings.
Good evening and welcome all of you for the first ASAMI webinar conducted by the Kerala chapter in the year 2025. And today's topic is about how to approach non-union by none other than Vasudevan sir from Kerala. I hope this would help the budding orthopedic surgeons for clearing their doubts and regarding the management of the non-union and simplify the management. So for the introduction of faculty, I welcome Kerala State Representative of Kerala, Dr. Dilip.
Yes, sir. First, I invite Dr. Vasudevan P N, Senior Consultant and Head at Angam Orthopedic Specialty Hospital, for the talk on how to approach non-union. He requires no introduction, the man behind the very famous Palka deformity course. He was a past president of Kerala Orthopedic Association and presently Vice President OSS. Over to you, sir.
Bolaji, I think.
Good evening, sir.
Yeah.
Good evening, sir. How are you, sir?
Great. Yeah. Now I think with all your permission, let me start.
Please, sir.
So today I'm going to talk about the art and science of Ilizarov in long bone non-unions. This is going to be an exhaustive talk on non-unions, compiling all my experiences in long bone fractures and what I understood from my experience and what my formulations on the managements. So let us start with the definition of non-union. You know, all rules are made to break. So non-union is also a rule is when a fracture is not united, even after 9 months, it is called as a non-union. Or with no visible progression of healing in last 3 months, he is called as a non-union. Look at this young man. So I've been showing this X-ray and clinical photo of him many years because it's very, very rare to see such an X-ray. See that it is even after 1 month, the X-ray shows perfectly healed tibia. But you can see whole bone is exposed. Whole plate is exposed. And it's an atom bomb. It can break at any moment. Though the X-ray says otherwise, that is not true. And you have another situation where total loss of distal humerus. Do we have to wait for 9 months to say that this is a non-union? There are situations where we have a day 1 non-unions. So you don't have to waste your time for nearly 9 months to describe it's a non-union. And you know, non-union is one of the most perplexing problems in orthopedics because of the wide spectrum of the types, from the simplest hypertrophic non-union to atrophic recalcitrant non-unions and infected non-unions, and wide spectrum of treatment from POP to fixators, debridement, flaps, grafts, antibiotic impregnated nails, beads, plates, and finally amputation. We always surprised why some fractures are hesitant to heal. So in addition to systemic causes, there are plenty of local causes. The local causes include the severity of the injury, the nature of the injury, the amount of debris and dead bones there, avascularity of the bone fragments, infection, instability, and malalignment. So soft tissue injury let it be traumatic or iatrogenic, it always kills the bone because soft tissue is the mother of bone. When a soft tissue needs bone for stability and bone needs soft tissue for viability, it's a give and take policy. Soft tissue always protects bone and gives it food. Bone always gives stability for the soft tissue to stay and work. So it's a community like living there. When a bone is fractured or it's a compound fracture, when both soft tissue and bone are damaged, we are stabilizing the bone not for bone healing, but for soft tissue healing. Once the soft tissue heals well, the bone is naturally heals. Many times it may not happen. So primarily it is for soft tissue healing. And remember, only living bone can heal in compression. So that is why in infected non-wounds and whatever way, you have to debride it, see the paprika sign, and because only living bone can heal in compression. And that doesn't need periosteum. It's an endosteal healing, directly end-to-end healing. So that doesn't need periosteum. But only living bone can do that. To heal in distraction, you need periosteal healing. Periosteum is a must. And until Illuthero, we were managing them by debridement, rigid fixation in compression by plating, plenty of bone grafts. And we have found many a time the graft got absorbed due to instability. Limitations were plenty because of the instability and infection. And many remained ununited or infected or became crooked like this. And we were not heard about distractions, malalignment, and lengthening possibilities in our life till that time. Somebody's mic is working, it seems. And in conventional methods, we had variable rates of success, and we had inability to get a length and deformity correction and function back. And many of them ended in a crooked deformity like this and short functionless limb and amputation after many years of agony. What was Illuthero's contribution to this? So we can classify Illuthero's contribution in two types. One is his principles and the other is his fixators. So when you look into the principles, the most important rule is the law of tension stress. And he taught us how to do a good corticotomy. And he taught us how to do a distraction histogenesis, how to grow bone, how to grow nerves, how to grow vessels, how to grow soft tissue and skin. And realignment strategies, again, biomechanical principles of bone growth. And what is Illuthero's fixator? The fixator is the one with the 3D stability and using tension thin smooth wires, olives, and pins, which was highly modular. And you can create any shape and correct any shape with that. But only thing is you need good pin and wire placement and where you exactly need it, because all the pins and wires are the warriors for us. They're like soldiers for us. They are doing the job for us to get the result. And you make a frame and you must have good soldiers to protect the frame and onto the bone. And bone should follow the orders of you through the frame, through the pin and to the bone. So that is the most important trick in treatment of anything in Illuthero. Because circumferential fixation, you have a three-dimensional hold, and since it is holding on to the periphery of the rings, in the central point you have a trampoline effect. And Illuthero fixator is axially very, very unstable. At each step of loading, the bone ends. If you are touching each other, they hug each other and goes back. That means an axial micromotion takes place. So you don't have to make the frame loose for that. That is the quality of the Illuthero fixator because it is holding the rings, holding the wire at the periphery of the ring. So in the central part, it will always work like a shock absorber. Now, how Illuthero can be used in non-wounds? Now, with the knowledge of Illuthero, you can do a radical debridement. So infection is not a big issue now. You can take out all the dead tissues. So there is no more bacteria coming there. Because we have the corticotomy in our hand, we have the technology to grow bones, and you can correct bone loss, and the corticotomy increases the vascularity, and you have the frame by which you can correct the instability, you can get docking, you can have a very stable frame plus docking that controls everything. And with that proper stable frame, you can completely correct the malalignment by realignment strategies. And it is such a small fragment. If you think so, you can always span the joint whenever you feel like. And the mode of treatment depends upon the strategy of our management on to a particular non-union. That is the only issue, because all strategies are same for all non-unions. So our strategies are different for different non-unions. So we have different non-unions, we have different types of strategies, different modalities of treatment. It is not one for all. Just putting a ring fixator around a limb is not an illusory method. It's only a ring fixation. Is it strong enough to carry out your strategy? That is the important thing. The fixator should be strong enough to carry out our strategy to tackle that problem. So the strategy must be well formed earlier. The frame should be as simple as possible. At the same time, it should be as strong as needed. As simple and as strong as needed. And what are the tricks of non-union healing? Again, I'm repeating it. The living bone ends. So assure that you have good living bone ends. And assure that they are all aligned perfectly well. And assure that they are all opposed well. The contact area, the surface area of contact should be at least more than 50%. And it should be stable without any shear force. So no bone like shear. So we want stable, axially stable contact at the non-union site. And if there is any limb length disparity or bone loss, you decide whether you need a correction or not. So this is what I call as last and LLD rule in non-union. Last is living bone, aligned, opposed, stable, and limb length disparity. So you check all cases, you decide, you can plan based on this last and LLD rule. Now, again, only live bones love compression and hugging and tolerate controlled distraction. They hate shear. They don't like shear. So they always like compression, like hugging, and tolerate controlled distraction, not like haphazard distractions. And remember, all deformities on a non-union produces mechanical axis deviation and results in malalignment. And mechanical axis deviation over a poor fracture anatomy create shear force. Shear always delays union, and shear results in refractures of a healed union. So shear we don't like. We don't want shear at any places. And deformity of a non-union may be intrafocal or extrafocal. When you have a deformity around the non-union site, that is called intrafocal non-union, deformity. When you have a deformity far away, like the non-union, that is called extrafocal deformity. Here you can see an intrafocal deformity producing shear. Here you can see an extrafocal deformity producing shear at the non-union, in addition to the intrafocal deformity there. So these are all shear force. So the extrafocal deformity may be in the same limb segment. You can see the extrafocal deformity, the same segment here. This focal deformity produces shear force at the non-union site. And that is the reason for this recalcitrant non-union of this lady. I will show you this case later. Or it can be from the nearby joint. You can see a equinus deformity. Normally, your tibiocalcaneal angle will be 120 degrees. Now it is 90 degrees. So that means there is about 30-degree equinus here. So when you have a equinus deformity, the mechanical axis calculation is not done from the angle joint. It is done from the head of the first metatarsal. The mechanical axis goes far away in front. That force will refracture the healed fracture. So it can produce a recurvatum stress on the fracture there. So that will result in non-unions. And it can be from the nearby bone also. You can see here a non-union in the tibia, and the fibula is maintaining that non-union. And it can be even from the femur, or it can be from the other side, anywhere. It can be nearby bone, not even that. Now look at this one example of this case, where one patient had a fracture shaft of tibia. He had a proximal tibial varus, middle compartment arthritis, and proximal tibial varus deformity. So the surgeon trickfully done a lateral entry and put a nail. And that fracture is completely healed. But because the proximal varus deformity, whenever the patient is walking, the nail is inside there, and I think some Mehul Khatri or something, no, his mic is open. Just close the mic. Yeah, now you can see the stress happening at the distal screw. And the patient has developed a stress fracture at the distal end of the nail. So there's an extrafocal deformity here, and that results in stress fracture in the nail tip. Now, the surgeon removed the nail, put a fixator on that, but still the real culprit is still hidden. And he corrected the distal tibial non-union, the fracture, and stabilized with the fixator. And as soon as he removed it, the real hidden enemy does the job. It still went back and gone for the non-union. You can see this displaced medially, and the shear force is still happening there, and it remains non-union. And the mission is completed. He had a very bad skin over the non-union side. So how to tackle this? So now you apply the last LLD rule here. Is he having a living bone? Yes, he's having a living bone there. Is it well aligned? Not aligned. There's an intrafocal deformity and extrafocal deformity. And is it opposed well? No, it is not opposed well. You need to have a very good opposition. How is it stable? It is not at all stable. A lot of shear is happening there. Is there a limb length disparity? No limb length disparity. So all this problem, do you have to open to correct all these problems? You don't have to open it. You can do a closed correction and correct the intra and extrafocal deformities and make an adequate frame for doing all this job. So that is what I did. I did a proximal tibial corticotomy, corrected this tibial varus. And the distal end, you can see the SUV, and with the SUV, I am slowly correcting it into the right position. So this is what I have done. So I corrected both sides. And after correction of extra and intrafocal deformity, it has completely healed. So the real enemy was the upper end. So I corrected and made into mild valgus, and that osteotomy healed. That is the original fracture site, and the refracture site is also healed. So we have different types of non-union based on the callus. You divide it, you can classify it hypertrophic, oligotrophic, atrophic, and pseudoarthrotic. Based on infection, you have aseptic and aseptic. But in Ilizaro, we have stiff non-union and lax non-union. So stiff and lax non-union. Infected non-union is again part of lax non-union. So in the stiff type non-union, you call it as hypertrophic non-union. In the lax non-union, we have pseudoarthrotic non-union, atrophic non-union, infected non-union, gap non-union. All these things are lax non-unions. In Ilizaro treatment, the strategies are monofocal treatment, bifocal treatment, and trifocal treatment, transport and transfers. A type is a monofocal treatment. Among that, A1 type, stiff non-union without any deformity, if there is no infection, you can always treat the conservative treatment like cast bracing is there, and you can do a closed nailing or even plating. You can do an Ilizaro distraction, in distraction or even in compression. That's the simplest of everything. I'm not going to touch that type 1, A1. A2 is a stiff non-union with deformity, where you can do an illusory distraction.
He was at 17 when he was put down by Buddha. Straightforward chance. Major.
It's a call shot.
Yeah. Hello? Hello?
Yes, sir. Please continue.
Is it audible now?
Yes, sir. Please continue.
Is just now or earlier?
No, just 1 second. It was.
Okay.
Hmm.
Now the slide is not moving. Yeah.
Yeah, moving, sir.
Okay, right. Type 2 stiff non-unions are non-union with deformity, where I do illusory distraction. And A3 are type 2 stiff non-union, A3, where you need illusory compression followed by distraction. So here in type 2, you can do a direct distraction, whereas here you need a compression and followed by distraction. And there are the A4 type, where an infected non-union or post-debridement case, you have decided not to do any lengthening, accept the shortening. That's for directly primary illusory compression. That's a A4 case. So I'll show you an example. And this is a B type of bifocal treatment, where depending on the shortening, if there is less than 7.5 centimeters of bone loss, it's a bifocal treatment. And more than 10 centimeter and less than 7.5 to 10 centimeter loss is C1. And more than 10 centimeters, this is called C2 and C3. C2 is double transport, olive wire transport, and trifocal. C3 is slow fibular transport. C3 is a fibular transport. Here you have transport, olive wire transport, and trifocal. Here you have plain simple transport. So I'll show you the cases again. Two types of stiff non-unions. Type 1 stiff non-union, where you have very minimal movement that is painful. So that means there's a good periostal attempt to heal, but not stable enough to consolidate because of the shear force happening around that area. So distraction is usually done out of necessity because you have a deformity there. But that will readily heal in compression provided there is no shear. For example, this particular boy, the stiff non-union with deformity, sclerotic bone ends, tiny seclusion, we can say tiny seclusion, but there is no sinus. There is shortening. There are no sinuses anywhere. So it's a well-contained infection. Sclerosis is not a sequestration. The sclerosed bone is only secondary to stress. So our problem is deformity, limb length disparity, and hypertrophic non-union. So when you apply the last and LLD rule here, do you have living bone? Yes. Is it well aligned? No. Is it well opposed? Yes, reasonably opposed. How is the stability? Very poor stability. Is there any limb length disparity? Yes, but that can be managed by distraction ranges. I don't need any corticotomy. So that means all this can be achieved by close correction. So make an adequate strong frame for correcting the deformity. This is the shear force happening. The patient's weight comes from here and the tibia, the opposite force goes up and that continuously produces shear at the non-union side. That shear force is producing the sclerosis around the living bone. Now, use the non-union site as a corticotomy to correct limb length disparity and deformity and correct a frame for it. Using the distraction hinges, distract at a slower rate to correct deformity and limb length disparity. So the child has corrected himself very slowly, no opening anywhere. No healed just by distraction alone. So LLD is corrected, deformity is corrected. So you can see the sclerotic bone just disappeared. It's healed by periosteum and the sclerotic bone has disappeared. This is A2 type of case, before and after. So whereas in type 2 stiff non-union, where you have a lot of movements, more than 7-degree movement and it's not very painful. If any deformity is there, that is easily correctable. So they are all radiologically may be hyper or normotrophic, but it is very, very flexible. So that shows the periosteal attempt is there, but not very, very reliable. So what we have to do is that may not heal by distraction alone. So these cases, you compress it and keep it there minimum for 3 to 6 weeks. So by that time, you allow the periosteum to heal. Once the periosteum heals, so this will get converted from type 2 stiff non-union to type 1 stiff non-union. Type 1 stiff non-union will heal by distraction alone. So now you can do distraction on that. So this is how you can convert a type 2 into type 1. For example, I'll show you the cases here. A type 2 stiff non, you can see some bone formation is there, but it is very lax. This is the story. You can see an interlocking nail which got infected. There's a secustum inside in the nail, and the screw started coming out. That's the secustum, and the whole screw went out, and the nail entered the knee joint. Patient developed a septic arthritis, and that is the secustum bone. And somebody removed the nail and removed the secustum, and it became like this. And then I managed it by Ilizaro. So I applied the rule again here, last and LLD rule. Do you have a living bone there? Yes, living bone is there. And is it well aligned? It is reasonably aligned but lax. Is it opposed well? No, there's a gap. It is not opposed well. How is the stability? There is no stability. Is there a limb length disparity? Yes, there's about 3 centimeter limb length disparity. So do you have to open it anywhere? I think we can manage it by closed method. The only thing is you compress it, convert it into type 2 into A3 into A2, and you distract it. A3 you can convert into A2, and then distraction will give you back the length. So that is what we did. The periosteal attempt not very reliable. We need compression for about 3 weeks minimum, and then distraction. So that is what I did. I just compressed it, and patient started walking. And after 3 weeks, we started lengthening like 0.5 millimeter a day, not like 1 millimeter a day, 0.5 millimeter, 1/4 millimeter morning and evening. I got the length back. You can see the good bone formation everywhere, and healed well and got his length back. This is again a type 2 stiff non-union, type 3, type 2 stiff non-union, which is coming in A3. This is a double non-union, more than 2-year-old. You can see shear force happening there. You can see shear force happening here. So many procedures has been done, but none of them was able to control the shear at this level and control shear at that level. So these two shear has to be controlled. Without controlling this, nothing is going to work. So there is a double non-union, more than 2-year-old, more than 12 surgeries has been done on him. The tiny sequestray, there is a shear instability. The middle segment is viable now. If I open that area, the middle segment will become sequestrated and loose and come out. So how to save it? You make appropriate frame, apply the last rule again here. Is it a living bone? To me, yes, mostly it is yes. Is it aligned well? Not at all aligned. Is it opposed well? Not opposed well. How about the stability? Very poor, you have a lot of shear there. How about limb length disparity? Yes, he has a limb length disparity, but I don't want to do a corticotomy because so many holes already everywhere. So let it heal, even that is more than enough. So I accept shortening. So I plan for a closed correction at both sides. So I placed the closed Ilizaro. I counted the shear by appropriate olive oil. The middle fragment was stabilized. You can see one olive there, one olive here. You can see another olive at this level. And counted all the shear, aligned well, and just compressed. He started working on 3rd day. In 2 months' time, it has healed. I retained the frame for nearly 4 months. You can see how easily they have melted each other. So that is the beauty of Ilizaro. You can heal them like a magic. The young little girl with pathological fracture femur, You can see the fixators applied across the epiphysis. In a few months' time, see the power of the epiphysis. That epiphysis can bend the wire with the shunt spins. It's a very thick shunt spin. It has just opened it like this, so that how much stress must have been taken by the epiphysis. And you can see the big cavity around that area, big gap at that area. It is not going to heal by any method. So this is how I saw the patient. So I removed the frame and kept it for a few days till the wounds pin sites are healing. Now I applied the last and LLD rule. Is it a living bone? Yes, it's a living bone. No sequestrum now. What about the alignment? It is aligned but lacks no contact, no opposition. The big gap there. Stability is not there, only gap. Limb length disparity is there, but I don't want to lengthen this segment where it's a very tiny, small little girl around 5 years or so. And I thought I'll just oppose it and stabilize it by open docking. I'm planning to dock this one into a hole into that and neutralize with the frame and make the child walk, because the distal end is very small fragment. I must span the knee joint. So I made a fixator like this. You can see one olive wire just to stabilize that into the distal femur and span the knee joint, perfectly spanned it, well aligned, and the child is walking with the fixator on that. And that is how we healed, just melted each other. You can see the epiphysis is not doing well, but overall it has healed well. So this was the final healing, and the epiphyseal insult is gradually coming to face. That is how I saw her last month, few years back. Now looking on to the lax non-onion, we have synovial pseudarthrosis, we have infected non-onion, we have atrophic non-onion. So now the hypertrophic non-onion is actually hypertrophic non-onion. If you don't treat well, it either go for malunion or it evolves into a pseudarthrotic non-onion. The healed periosteum gets converted into a capsule. The cavity gradually becomes a pseudo joint. So that pseudo joint formation you see only in the hypertrophic non-onion's next stage evolution. Whereas the atrophic non-onion, you can see there is absolutely no contact between the bones, no periosteal healing. It has multi-directional translational movement and absolutely painless. In illusory method, the treatment of pseudarthrotic non-onion or atrophic non-onion or septic non-onion, all are same. There, you debride the non-onion site, oppose them, align them, and stabilize. So let it be any of these things. The treatment is same. So debridement convert them into a gap and manage the gap by shortening or transport or lengthen by corticotomy. Now acute docking. If the gap is less than 5 centimeters, you can acutely dock it provided there is no neurovascular deficit distally. What are the advantages? That ensure good contact and good intrinsic stability. And that ensure earlier healing, because bone starts healing only when they are in contact. In a transport, it takes time to get a contact. Now it heals faster. And the stability makes them walk better. The stress on the frame is much less when you do an acute docking. And the soft tissue gap is also closed well. And it's easy to correct shortening than to do a gap, correcting a gap. So there is a lot of advantage of gap docking. But we do have some disadvantages too. When you have a acute docking, your wound closure is going to be difficult. You must plan an appropriate incision earlier, either transverse, lacy S, or Z-plasty. What distal vascularity may be at risk. And sometimes you may have an ugly soft tissue bulge at the non-onion site. You can have temporary flaccidity of the muscles. And limitations of docking. Up to 2 inches may be okay in mid and upper leg. Lower third leg, even 1 inch, sometimes can land up in trouble. In thigh, you can go up to 2 to 3 inches without any trouble. The total bone loss is equal to gap plus shortening. It is corrected by lengthening corticotomy. So that is bifocal treatment. In badly infected non-onion, corticotomy is done after 6 weeks of, especially in a interlocking nail infected case. Generally, I don't like to do a corticotomy immediately. I would like to do a corticotomy after 6 weeks in interlocking nails. In a plate non-onion, I don't wait even up to that much. Probably I will clean it very well, do a corticotomy in the same sitting. Because I can save one surgery. In acute docking, if not possible, we can always resort to bone transport, or even you can do a partial acute docking and then controlled bone transport later. So that is known as bifocal treatment. Gap and shortening is equal to bone loss. You assess after debridement. There are 3 types: B1, B2, B3. If shortening is less than 7.5 centimeter, you do just plain lengthening corticotomy. Bone loss less than 5 centimeter, you can do acute docking and convert it into shortening and do lengthening. When bone loss is more than 7.5 centimeter, you may be having gap plus shortening. You may have to do a partial docking and then transport or gradually further docking. And we have been taught that infection burn in the fire of regenerate. And what I've seen in my experience, I've not seen corticotomy is not healing infection. It very rarely does so. And I learned from this case. This is in 1993, one of my earlier cases. I was very much proud about being an illusory surgeon. So I thought this infection is going to burn in the fire of regenerate. A young boy. I applied last rule. Living bone. No, there's not a living bone. But my corticotomy is going to make into good. And alignment, how is the alignment? Reasonably good. However, the opposition, there's not good opposition, but some gap is there and that tissue, but we can compress it and see what is happening. Stability is not there, but with the frame, I will stabilize it. And limb disparity is there. I will do a corticotomy to create the fire around that area and do that. And open for debridement. That was originally planned, but I was relying upon more of Ilizaro, so I didn't open that area and I didn't do these procedures. So the corticotomy for LLD was done. You can see the corticotomy at that level. And this is a small sequester around that area. I continuously compressed it and did a lengthening at the upper end. It is healed without any problem. It has healed. It took little extra time, maybe around 1 year or so. But he ate my brain for 2 years because the sequestrum was there. On and off, he will call me. I am having infection there, pus coming out. 1 liter came, 2 liter came, and some few bone came out. So he was eating my brain for many, many years. And finally, it has settled down. So nowadays, I don't want to waste my time on that. It's better not to rely on this fire. I trust on modern concepts of infection management like debridement, antibiotic therapy, and adequate stability using Ilizaro fixator. The indication for corticotomy is not for fire, but for lengthening. It increases the vascularity as a defunctioning osteotomy. Many a time, the corticotomy works like a defunctioning osteotomy, which is otherwise known as parafocal osteotomy of Paltrinieri, which is described in 1961. All of you must be knowing parafocal osteotomy. In a fractured neck of femur, you do a intratrochanteric valgus osteotomy. It's a parafocal osteotomy. Similarly, I will show you an example here. You can see this one, a shear, an oblique non-onion. The living bone, yes. Alignment, okay. Opposition, not very good opposition. Stability is not good, there's a shear. Limb disparity is there. So I can align and oppose and stabilize by closed method, and I can do a frame on that. So I will be doing it like this. So I'll do 1 ring on the top at the fibular head level. If I am doing it, I'll do a 4-ring frame, customized frame, 1 ring at the fibular head level, 1 ring just 1 inch above the ankle, and 1 ring close to the fracture site on either side with a gap of about 10 to 12 centimeter gap. And because the shear, I want one olive wire here and one olive on the lateral side. The lateral view, I want one olive posteriorly, that is posteromedially and anterolaterally. So if I keep everything there and I'll keep the patient on a fracture table, give a traction. So that will align everything together and put a 4-ring customized frame, parallel wire on the top, parallel wire below, put a frame on that, olive wire posteromedially, anterolaterally, and stabilize it. Then if you want any pulling, you can always pull it and do a compression between these two. And unfortunately, it was not done by me, it was done by somebody else. He did a beautiful corticotomy. It was above the upper ring was above the fibular head. There is no fibular wire. And the second ring, instead of having it at this level, he kept it very near the corticotomy. When you are going to distract here, from there, the control on this fragment is very less. When you push it, this can move. If you have the ring around this area, the control on the non-moving set is very high. That is why you must have a frame around this area. Here, the very near the fracture site. It would have been better to have a little more down there, so you can have a better radiological appearance. I mean, you can visualization better there. And a distal ring. So not very well done. And not opposed, because you can see the gap there. And there no olive wire has been placed. Shear is not counted. And third ring is very close to non-moving. So not done very well. But he had done a beautiful corticotomy. Now what happens? He distracted it. You can see it is opening up. You can now see the untensioned wires. So non-moving side got drifted off. Some distraction has happened at that area. And you can see good callus at the region. As this is drifted off, you can see newborn formation around that area. And you can argue that this newborn formation has formed because of fire of region rate. Is it really so? What really happened was, there is no olive wire here, nothing has been placed. By corticotomy there and got a gap around that area. The shear, that is the compression from the top, when it was a one single bone, the loading produced a shear here. Once there's a gap here, the loading is partly neutralized around this area. The shear is being abolished. That the shear was shared by the corticotomy. So this is the exact reason for a parafocal osteotomy. This shear is partly shared by the gap at the corticotomy, and this non-union heals because of this. So this is the parafocal osteotomy of palpatine. So, and when to open a non-union? If you want to remove something like a sequestre or implant, you open the non-union. If you want to put in something like a bone graft or implant, you open the non-union. And if, again, the most important thing for illusory surgeon is, if you don't like the shape, reshape to get good intrinsic stability. For example, in this case, so this is a transverse case, transverse fracture site, you can just compress it. Here, this is stabilizable. You can put a 2 olive on either side, control the shear, and now you can compress it. No more shear happens. You get the axial movement is converted into compression. Shear can be converted to compression by doing an olive wire. But here, you cannot accept the shape. You have to reshape it like this. Either of like this. This again has to be reshaped. This one also has to be reshaped. So reshape the bone ends for good opposition and to avoid shear and to get good intrinsic stability. For example, here, a oblique focus, if you compress it without any shear, without any olive wire, it will happen like this. If you keep a olive wire on either side, it will behave like this. So you can now see that the olives convert shear force to compression. So I'll show you an example here, a lower tibial gap, flap, and poor fracture shape. So this you cannot accept it. You have to change the shape and make a good contact, good intrinsic stability, and that will produce shortening. Then you need a corticotomy in top. That is actually a B2 type of strategy. So this is what is we are planning. You have a living bone there. The alignment was okay. Opposition was bad. A gap is there. Stability is not very good. And there is a limb length disparity. You need to do a corticotomy. So I had opened for opposition and stabilization. And I need a corticotomy for limb length disparity. So I docked it together. You can see good docking, good opposition. But to my surprise, you can see a post-operative X-ray, you can see the deformity. But my frame is strong enough. I can correct my frame. And you can see the corticotomy that is correcting for the length. And I did the frame. I corrected the frame. You can see now the frame is bent and the bone is straight. That is the beauty of Ilizaro. You can correct it post-operatively like this. And you can see the frame is bent, bone is straight. So that is the final result. That's the bifocal treatment, widened and our horizons. You can excise whatever bone you feel like removing. You can still go and get them back into right position. Now we go on to the C-type non-unions. Transport. C1 is a transport. C2 is a double transport. Oliver transport, a trifocal. And C3 is a fibular transport. There are so many problems of a transport like deflections, mal-docking. You may have to reopen that area. Delayed healing of non-union. You can have a poor regenerate. You can have a dense scar which can act as a block to transport. You can have a soft tissue and skin invagination. And you can have soft joint contractures. Here you can see a poor regenerate. You can see the skin invagination. You can see the joint contracture. So now you have to correct the equinus. So this hypertrophic region rate most probably will grow once it is touching each other. This bone will come back. I think it is not hypertrophic. There's no mechanical stimulus happening there. That is why it has produced hypertrophic-like feature. So you remove this area and correct the invagination, dock it together, so that will heal. So I'll show you another case of non-union on an orthofix, not very well aligned. I remove the frame. That is how the scar. And you have a living bone. Alignment is not good. Opposite is not good. Gap is pressing. The stability is not good. Limb length disparity is, it is not there, but only gap. You cannot oppose it. You need bone transport or open docking SOS later. So here we decided to do a corticotomy and transport. Because the funny shape here, you can see the bone is getting deflected. So this I could have been corrected by putting a cut olive from here to up. But you know, that area was a scar. I don't want to put any pin there. So I just left it like this. Let it go to that side. Once it is reaching there, I will open that area, put this fragment in front of it so that this posterior spike will prevent the backward movement of the transport fragment. So, and it will automatically give a compression at the posterior cortex. So that was decided. You can see that is this posterior fragment is going backwards. And I just put it anterior to the distal fragment. At the second stage, you can see the regenerate on the top, well consolidated, all healed. So this is a young man with the 12 days after RTA. He was advised above amputation. And you know, this is going to be a tough, difficult non-union. You can see the gap between here. You can put a fixator, but all the muscles around the bone, around the leg, is in trouble. And whenever he is moving the foot, this muscle was moving. If I can stop this movement of this foot, then these muscles will supply the bone and will give more blood supply to the bone. Probably I can get more bone formation. If I am allowing this to move, the soft tissue will move around this area. I'll have more of a dead bone than I can manage it myself. So this was a fixator. Soft tissue was not stabilized well. Only one pin here. Whenever he is moving the foot, this fragment was moving above and below around this. Because one pin is not going to stabilize it. You can see this can move around that pin. So the foot was loose there. I stabilized the foot and added few more pin in the middle fragment. And I didn't do anything. I retained the original fixators, just added a ring on the top, just added a foot ring and neutralized it. So the leg is under rest, the muscles are rest, the muscles are giving blood supply to the partially viable bone, and I just covered it as much as possible. I know this is not going to save all the tissues and all, but whatever I am going to get it, let it be there. So I am not going to do a primary Illuthero on this. So let it heal the soft tissue. Illuthero is only for primary correction like this. We will manage it later. So this is how the fixation has been done. And after 10 days, I could save good amount of bone. Only this much bone is necrotic, and this much area I can see good soft tissue cover. I did a skin grafting on top. And after 6 weeks, I removed all the dead tissue, dead bones, and did a upper tibial corticotomy and another lower tibial corticotomy around this area. And I put a temporary short rods. Do we need a flap to cover this area? I didn't do any flap. I would like to see what is happening in this case. You can see now the bone is coming down along with its soft tissue. Here the bone is going up along with the soft tissue. You can literally see both bones coming together from the top and below, meeting at that point, under vision, living bones, they just meet at that point. You can see the corticotomy and corticotomy on the top. So it slowly came down. You can see the full rods for transportation. This comes down, here it is going up. So bifocal transport, that is C2A. So the gap has been closed. Bone ends got docked. The wound has healed on its own without any flaps. You can see the skin quality now. It is completely healed. And the foot frame was removed. And later, this full frame was removed. You can see the healing. That is the regenerate from the top, the regenerate from below. That's the final X-ray and CM. The X-ray and the clinical pictures, all completely healed. A happy ending. Look at the smile. This is 2A, double transport. This fellow, I think I have done only very minimum number of Oliver transport. He was my junior in medical college. He had a gap non-union and another distal non-union here and a gap non-union around that area. He had injury. He had about treatment for about 18 months, multiple surgeries, finally posted for above knee amputation because there is fracture up to here. There is stump length is not there. He was posted for above knee amputation and he just came for a second opinion to me. So he had a living bone. No, this is a dead bone. That has to be excised. Is it aligned? Not aligned well. Is it opposed? No, there's a gap. Stability, there's no stability. Limb disparity is not there, but only gap. That need debridement. The gap you cannot oppose it. It need bone transport. And later, an open docking and bone graft may be needed later. But where to transport? There's already a non-union here. You cannot transport this non-union up. So you need to do a corticotomy from there, but it's a very tiny fragment. I cannot put a ring on that. So I thought I'll just put a olive wire transport to pull it downwards. And in the distal end, there's another non-union there. If the bone ends are living there, it must heal in compression. If it is not healing, then possibly we'll expect that the periosteum has healed and it may heal in distraction if it is not healing in compression. So that we'll keep it at a later stage. So I did a debridement. Where to do the corticotomy? I did a corticotomy on the top and 2 olive wires. You can see the olive wires being connected down here. You can see the device by which you pull the olive wire downwards. 2 olive wires, and I kept one ring distal end. It's a dummy ring. I kept a dummy ring around that area. So as soon as the fragment comes down to reach here, I have to change it into full wires and for compression. Because the olive wires will produce deflection in the soft. It can deflect in the soft tissue. That I need to correct it as soon as it reaches around this area. So I plan for a dummy ring at that level. You can now see that the fragment is coming down. Once it reaches there, I put the dummy ring, the wires on the dummy ring and compressed it. So the distal non-union was not healing even after 5 months of compression. Now it has healed. I just tried a distraction. It has healed in distraction. You can see it is healed in distraction. In compression, it was not healing. Now it got docked and all healed. That is how it is healed well. This is a case which I showed earlier. 25-year-old lady with 2-year story, grade 3 compound fracture, more than 15 procedures, microvascular flaps, Ehlers and everything. Totally scarred leg and posted for an amputation. Now how to correct it? It's a recalcitrant non-union, posted for amputation. I did a malalignment test. You can see the shear, extrafocal deformity and an intrafocal deformity. So the extrafocal deformity was a real enemy for the non-union. So apply the last and LLD rule. There is a living bone, not a good living bone. You need debridement around that area. Alignment is poor, opposition is poor, stability is not there, LLD is there, and you need a debridement, open docking, opposite, extrafocal deformity correction, and correction of the LLD. How to manage it? You need a limb length disparity correction here, an extrafocal deformity at that level, corticotomy, and open docking, get a correction like this. So this is in the AP and lateral preoperative planning, correct, align everything. It must heal because all the shear is being converted into compression. Now this is how the frame was working. Dock together, one corticotomy here, another corticotomy here for all the correction. Now it all has been corrected well. I did the lengthening little bit here, little bit lengthening here, and compression at that level. After realignment and lengthening, that is how the lady was on walking. There's a muscular foot drop, but still you can see the regenerate forming. The regenerate is healing. You can see the regenerate and the non-union has healed. And that is the final long-term follow-up before, and this is the final X-ray. Now you can see the power of planning. You plan whatever you want, you get whatever you need. So you plan, you get it. So that's it. You can do it. The main enemy is the shear. You control the shear. But there are some situations where you have a big gap, microvascular fibula more than, you can see the infected microvascular fibula around that area. The whole area was infected. And long term, you have the option of transporting from here up. There's a fracture up to here. So from distally, if you transport it that much higher up, in a 55-year-old man, will take very, very, very long time. So I applied the last and the LLD rule. It will be very, very difficult to correct the gap. So then I thought, since he has a fibula on that side, you can correct that fibula, cut the fibula, and transfer the fibula slowly into this. In about 3 weeks' time, you can fill the gap and you can remove the frame early. So that is what I did. I did the fibular osteotomy at that level, fibular osteotomy at this level, and distracted this tibia up and this tibia down. And you can see the device by which you pull the fibula anteromedially along the interosseous membrane direction. So once it comes to the level, I opened that area, reopened it, docked it to the top, and docked it below. That is how it has been docked. This is a device by which you pull. You can devise anything by which cut only you can pull it. That is how it is healed. A slow fibular transfer. That is the result. The fibular hypertrophy. It is not the fixator, but our strategy that heals the non-union. Make a good stable frame to implement your strategy and help the bone to heal. The decision making is in a clinical situation is a complex one. There is no cookbook method. If strictly adhere to intrinsic and extrinsic stability, axial alignment, vascularity, and function, Mother Nature will heal it. I'm ending with the one small boy, 5-year-old boy with 9-month-old non-union. You can see he was referred to me for elizero of the forearm in a 5-year-old boy. His story is he had a distal third both bone fracture. Probably I will only manage with the plaster at that age. So they did a open K-wire and that got infected and K-wire is removed. It remained as a non-onion and the infection got controlled, reopened, resected the non-onion of both radius and ulna. Ulna was shortened. Again put 2 K-wires on the radius and 1 wire for the ulna. And this is how it has been managed. So that got infected. That wire was removed. And then he developed a stress fracture in the ulna and both started bending. And at that stage, he was referred to me for elizero. He cannot even afford a POP. His mother was ready to sell his house and come for an elizero with me. Then I just asked her, you give me 6 weeks time before selling your house. I just put a POP cast on him and planned for wedging. I did the first wedging, did a second wedging and third wedging. And in 6 weeks time, this is what has happened. So he has no deformity now except shortening. And maybe he has a facial insult of earlier surgery. He may have facial growth problem later. So many times, common sense prevails on many of these decisions. Bone is a plant with the roots in the soft tissues. When its roots are damaged, it requires not the technique of a cabinet maker, but the patient care and understanding of a gardener. This is a word from Girdlestone. Thank you.
So, good evening, sir. This is Ram Karthik. Small doubt.
Thank you, sir. Thank you, sir, for making the very complex topic looks very simple. Next, we have invite Dr. Cherian Kovoor for case discussion on non-union. He is a senior consultant in pediatric orthopedics and limb reconstruction at Astor Medicity, EMC Hospital and Specialty Hospital, Kochi. And he was past president of Kerala Orthopedic Association and Kochi Orthopedic Society. Was a former executive member, ASAMI, India. Over to you, sir.
Shall I share the screen?
Yes, sir. Please share. Yeah.
Now, one of the cases I wanted to present was, can everybody see it?
Yeah, you can see, sir.
Yeah. I just wanted to, this case presentation is about conveying a message. Close fractures are not always benign. Now, 24 years old male, history of road traffic accidents on January 23rd, 2016, vital stable, all the vitals are stable. He had a fracture both bones, right leg, close fracture, tibial shaft with intact patch fragment and segmental fracture of the fibula. This is the X-ray. Very innocent looking X-ray. This is the normal close fracture that you would see. So we planned for a closed intramedullary nailing and the tibia interlocking nailing. Fortunately or unfortunately, or rather fortunately, I'm using that word, it got delayed due to various reasons, basically insurance problem and all that. So after about 1 week, he started complaining about discomfort in the POP slab, and on removing the slab, skin had started to blacken and unhealthy soft tissue sloughs and blebs. So this is the picture on removing the POP after 1 week. Nothing else was done, just a POP slab was given. So we decided to wait for demarcation, but then we started getting fever spikes. So we planned for debridement and external fixation. So fracture site exposed, but viable bone. So we decided to do a flap cover, but again, unfortunately, the patient developed pneumonia. So we had to again wait. So when the patient was fit, by the time we had missed the bus, And necrotic bone, we had to resect about 16 centimeters of dead bone. So the only option is the patient went to the plastic surgeons. They did a vascularized fibula graft. It failed and it was removed. So it came back to us again. Now what? Fortunately, the wounds are healed by grafting. This is the pre-op X-ray. So we did a bifocal iliceral ring fixation, opened up the fracture site, removed the intervening skin, grafted areas, all the made raw. And now we had about 17 centimeters of gap. So this was the iliceral frame that was fitted, 3-ring frame only. And you can see the bone and soft tissue defect. So this was the 3-ring frame and started transport. Fortunately, it was good regenerate right from the beginning. Docked, and we bone grafted it. We didn't want to delay again much more by waste time. So we bone grafted it to get the union faster. And we got united. And just before frame removal, there is a raw area which fortunately healed up without much of an issue with POP cast. Frame removal. So the total time taken was 18 months. And this was 4 months after frame removal. This is the clinical picture after 4 months. This is the picture after 7 years later. This is the end result after 7 years X-ray. And this is the gate. So the message I want to convey is check for soft tissue post-injuries always. The true skin color will appear only later because this devitalized skin may not show immediately. And one good guide to the viability of the skin is sensation of the overlying skin. That is a good guide to viability. And assistance of plastic surgeons is very helpful, and successful result needs a teamwork. Thank you. Shall I present one more?
Yes, sir. You can, one more case, then we'll discuss.
This is another interesting case. Iatrogenic ankle destruction. The 9-year-old boy had a very close fracture left tibia, treated with Ayurveda, skin breakdown over the ankle, then went to a medical college. So this is the initial X-ray. I can't see the fracture anyway. Anyway, went to the medical college. This is the picture. The fibula was, lower end of fibula got exposed and it got resected. So there was a lateral wound. The fibula got exposed, resected lower centimeters, and somebody put it on next fix. Then the shuttle game started between the orthopedic surgeons and the plastic surgeons. The orthopedic surgeon said we need a flap cover, and the plastic surgeon said you remove the necrotic bone. And ultimately, the tibia and talus also got exposed. So this is the tibia. It's not the fibula; it's the tibia. In the close-up view, you can see the talus also. And in spite of that, the boy was walking with a painful stiff ankle. He was still walking. The lower end of tibia and talus got sequestrated. We are not sure about the calcaneus viability also. So we warned the relatives about the high probability of BK amputation, because without the calcaneum, there's no point in preserving the leg. You can't do any infusion or anything without the calcaneum. So we took him up, and 5 centimeters of tibia and the exposed talus was resected. The rest of the talus was viable. Ultimately, we had with the 6 centimeter gap, and the iliceral frame was fitted. So this is a clinical picture post-op. So double-level corticotomy we did, 6 centimeters of bone defect. Although it's not necessary, we just did that. Most of the time, single-level corticotomy is good enough, most of the time. And transport, and docked, and fusion and consolidation, ready for frame removal at 10 months. So the soft tissue defect closed without any flap cover. As in the previous case, bone and soft tissue defect at the same level. Without exposed viable bone, with bone transport, it automatically closes. This thing. This is 8 years follow-up. And this is the end result. This 14 years later X-ray. So always cover the viable exposed bone to prevent loss of bone. And bone soft tissue defect at the same level, no need of a soft tissue cover. Bone and soft tissue defect, even if it's viable bone, you need a soft tissue cover to preserve the viable bone. But otherwise, bone and soft tissue defect at the same level, you don't need anything. Thank you.
Very nice case, Cherian.
Thank you, sir. Cherian, sir.
Thank you, sir. Next, I invite Dr. Jeejesh Kumar PK, Professor of Orthopedics, Government Medical College, Calicut, for case presentation. He is a regular faculty for the Elizaro and Limb Construction, national international workshops, and he has multiple publications in national and international journals. Presently, he is a EC member, South Zone, ASAMI, India. Over to you, sir.
Thank you. Thank you, sir. So I'll be discussing 2 or 3 cases, depends on the time availability. So we'll move on to the first case. So this is a very basic case I'm going to discuss, and it will be for those who have started Elizaro. So infected non-union tibia middle third, how to approach this patient. So this is a 34-year-old man presented with discharging sinus, as you can see here on the clinical picture, after 8 weeks of injury, and he was on above knee plaster cast following that. So, and he had a history of RTH before that and sustained type 3A compound fracture, and initially treated with external fixer followed by the above knee plaster cast. So these were the problems when the patient comes to us. There is the non-union, as you can see, middle third, and infection and bad soft tissue status, because once you open this area, yeah, you can have the soft tissue defect you can expect. So there's an anticipated shortening also is going to expect. So the pus culture sensitivity shows sensitivity to piperacillin and ciprofloxacin, or Pseudomonas organism was there. So how to approach this case, or how to manage? It's a very simple, straightforward code. So you had learned from the Vasudevan survey, and now you heard how to manage the non. So the treatment is, first thing, always eradication, the aim for the eradication infections, how to eradicate. So debridement is the answer for the eradication infection. Then you can add additional antibiotic beads or stimulant, depends on the use. And next, the fixation part. So how to fix? That is the next question. So you can have the Elizaro or LRS, or you can have the 2-stage procedure, that is first eradicate infection followed by the definitive fixation or internal fixation. So in such cases, can we do internal fixation? So how to decide about this? Is there any protocol for this? So this all depends on the severity of infection. If the infection is severe, then you may not be able to put the internal fixation. So please note, somebody is talking in between. So how to decide about this? It all depends on the severity of infection. So is there any protocol for this? Can we add internal fixation, or can we proceed with Elizaro or LRS? So you have infection severity score. This will tell you, this could help in grading the severity of infection, and you will get an idea of the prognosis for the need for any specific treatment or repeated surgical treatment for the infection. So here in this scoring, you have the different headings, that is sinus, skin conditions, sequestras, discharge, amount of discharge, the implant, whether it is external fixation or internal fixation, and the treatment data. So these are the various factors, that is 6 factors, and each has got subheadings and points. Then you have to calculate all these points together, and you will get a point and convert into 100. So that is the way of scoring this infection severity score. So the example is sinuses means, is there a nil? It is 0. If it is fewer dried, that means 1. Then multiple or active means 2. So you add all these together. If the score comes between the 25 to 30, then after thorough debridement, you can go ahead with the internal fixation. That is, your infection severity is less. So if you are confident of your debridement, then you can proceed with internal fixation. Then if the score is 40 or less, then you can decide debridement plus external fixation. That external fixation can be Elizaro, LRS, or anything. If the score is high, then you need a stage surgery. So this will help you or guide you when there is an infection. So in this case, the total score was 40. So was decided to do a debridement action fixer. That is with the Ilizaro. So that's about the fixation. Then a soft tissue part, because such a case, when you open it, you will have definitely there will be a chance of soft tissue defect. So how to deal soft tissue defect in such cases? So either you can allow the secondary healing or vac dressing followed by SSC or flap coverage. So usually the plastic surgeon, if you refer to this, they will go for the flap coverage. So this is a reconstructed ladder by the plastic surgery people. That is from the healing by secondary intention to the free flap. There are multiple options in between. That is called the reconstructed ladder. As an orthopedic surgeon, you can have the other method. That is, you can reduce the wound size. That is, suppose the wound size can be classified into alpha, beta, and gamma. So the gamma means large wound. There you can convert to reduce to alpha or beta type by doing an acute or shortening or in a deformed position. Or if the soft tissue is very big, then there's a technique called open bone transfer. Then later you can do the skin grafting. Then you have the choice of vac dressing followed by the SSC. So these are the methods you can reduce so that you may not need to depend on the plastic surgeon. So in this case, so we decide to debridement and followed by the fixation. So now coming to the Ilizaro fixation. So such a simple cases, how many, the questions will arise is how many rings, 3 or 4? Or should I remove the butterfly fragment? Should I make the bone ends transverse? Or can we do without this transverse making an end? So these are the questions arise when you do such a case. So this case was treated with a 4-ring concept, as you can see. So it will give, as it's a middle third fracture. So you'll have the more stability with a more spanning. As you can see, the spanning is done by the either the shank spin by attaching the rancho screw. So we can have all the more spanning of this particular fragment. So we will get more stability. And another method is that is intrinsic stability. Here you can see the one fragment is insulated to the, that is telescope into the other bone marrow, other bone fragment medullary region. So that way you can give a more intrinsic stability. So that, and again you compress it, then again it's add the stability. So that is the way you have to add the stability, both intrinsic and extrinsic. Extrinsic by the frame itself. So here when you debride, the butterfly fragment was not had a good soft tissue attached, so I didn't remove that. So these are the follow-up X-ray where you can see it is well uniting, and the fragment also getting uniting with the parent bone. So these are the final picture when it was united. So you can see the bone defect was very healed by this secondary healing here. So the principle followed in this treatment were when such cases middle third fracture comes, you can give a stable fixation by 2 ring above and 2 ring below. When you want to attach rings, proximally you can add 3 wires and 1 shank spin. In the middle 2 rings, you can 1 shank spin and 2 wires is enough. Then the distal third, you can apply more the 3 wires and the shank spin. So that's how you can add the stability to that particular case. And internal, already I told, internal mechanical stability is by the telescoping of bone ends and the compression. And the biology. So basically in non-union treatment, you have to improve the biology and the stability. So here the biology you can improve by the debridement. And you can add antibiotic beads if needed. And soft tissue coverage is another part of this management. That is, you can shortening the bone, reduce the bone size, vac dressing, and followed by, you can have either skin grafting or secondary healing. So these are the principles we learned in this first case. We'll discuss on the another case, infected segmental non-union of tibia. So here, it's a lady, 27-year-old lady, 4 months history of RTA, presented with discharging sinus over leg and pain and swelling and fever. So she has swollen leg, discharge signings, abnormal mobility, equinus contracture, mild shortening, deformity, and there was no neurological deficit. And she had a history of any posterior tibial artery injury also that was got repaired. So these are the X-rays where you can see this is a case of segmental non-union, where you can see the plate is going to fail, and it is failed already. You can see lysis around the screws, infection. It's basically a segmental non-union case. So ESR CRP was traced, and it was an MRSA when it was cultured. So the problem you identify the problem in this case. These are the problems. That is, infection is there, both intramedullary and the extramedullary. And the implant failure is there, segmental non-union is there, and there's a deformity and shortening. And distal fragment where you can see the green arrow, that is a doubtful vascularity because 3/4 of the circumferential bone loss was there. So when you debride such cases, you expect a bone gap there, So you have to prepare for the bone transport also. So how would you manage or how do you approach this case when such case comes to you? So you evaluate further with all investigation, whatever you need. So blood investigation, first culture and sensitivity, then you do because there is a vascular injury, you do the angiogram. You can do the nerve conduction study also. So here, this was the past history because it's a simple, it was a type 3C open fracture where you can see this is the initial X-ray. And you can see CT angiogram shows the posterior tibial artery was cut here. And it was managed very well. That is, revascularization was done, flap coverage was done. But they had nicely applied this plate also. Unlikely the everything got infected. That was the scenario. So when you see such cases, this could have been you are in your mind, you could have an idea that this could have managed by 2-stage, by external fixer application followed by the definite treatment. So here, what are the treatment options available in front of you? So you have to remove the implant, that is implant removal and thorough debridement. So then followed by a definite fixation, or you can have the 2-stage fixation. If you score it, here score comes 60. So what it says is higher the score, you have to go for the stage surgery. That is, first you debride, external fixator, followed by the definite treatment. So here I plan like that, debridement, stabilization, external is followed by, or the primary L0 depends on the severity of infection. And prepare for the bone transport also. So if L0, how many rings, whether 4 or 5 rings, when you want to resect that distal vascular bone, then how to transport, where to apply. These are the questions arises when you do L0 in such cases. So where to do the transport if you have such bone has to remove. So 5 rings means you can have it like this, or if you remove, then you have to think about how to fix it. So this was thoroughly debridement, was all around the bone was exposed, and you can see the bone is like entire top to bone. It is almost like a sieve, and non-union, you can see the distal fragment only is 1/4 of the circumferential bone is only present in the distal, but it was vascular, so I didn't remove that. I retained the fragment. So since I initially planned the external fixator followed by the definite treatment, I cannot put any external fixer there because you can see the bone is entirely sieve-like. So I proceeded with the L0 4-ring construct here. So you can see the proximal fragment I span with the shank spin, and the middle fragment you can see the more spanning with the shank spins, and the distal fragment you can see I put a antibiotic Siemens spacer there also. So 4-ring construct with a Siemens spacer, debridement, all things done. Well, give the stability and you add the internal stability by giving compression. So these are the follow-up X-rays. Then I plan to do the bone grafting at distal site, but when I remove this Siemens spacer, I found the bone is getting hypertrophied, and I thought of not doing bone graft at present. So I waited for that. So as the follow-up 9 months, you can see the bone is getting hypertrophied. So I didn't do any bone grafting there. So this was after 9 months. She was well united. As you can see, the bone is getting hypertrophied. So here, biology is improved. That is why the bone is getting hypertrophied and the stability is improved. So you're getting united. So the principle here is the biology is improved by the debridement and the stability by this maximum spanning fragment with adequate compression, and here you can expect an equinus. So better to wait there early and you do a Velcro strap with a chapel so in the night time so that you can prevent the further equinus formation. So that is the principle used in this case. So I will discuss one more case, tibial non-union with a gap. So this was a 40-year-old man presented with an external fixator over leg with a discharging sinus for 4-month duration. As you can see in the X-ray, the bone fragment is avascular here, about 6 to 7 centimeter bone. And he had a type 3B open fracture of both bone legs, followed by an history of RTVA. RTA, and it was got infected by following multiple debridement, debridement, and these were the problems when you want to plan as such cases. So the infection is there, bad soft tissue, around 6 to 3 centimeter, 6 to 3 centimeter soft tissue loss, then wound extending up to the proximal metaphyseal area, and the bone defect around 10 centimeter. There was no distal neurovascular deficit here. So in this case, how do you approach? So what is your management? So similarly, first thing is the control of infection, debridement, IV antibiotics, culture, dead space management, then soft tissue, as I already described. Now, soft tissue defect, you can, these are the options: vac dressing, flap coverage, or open bond transport. I decided to vac dressing and SSC here. Now, next part is the bond defect management. How to manage? You can have the various methods: masculine technique, acute shortening and lengthening, or bond transport through the induced membrane. So in such cases, is there any protocol for this to decide whether which plan I am going to do? So this is an algorithm for management of bond defect. It is given in the January 2021 strategies in trauma and limb reconstruction. So this is the algorithm. So basically, in the left side, you can see alpha, beta, gamma soft tissue defect, and the top you can see the bond defect. So less than 2 centimeter, 2 to 6, and here this case comes, it is a beta soft tissue defect and a 6 to 12 centimeter bone loss. So here the option is bone transfer through the induced membrane. So this is according to this classification. It was published in 2005 JBJS, where you can see the classification of the soft tissue defect and the bone defect. So in this case, how many rings? That is the question. 4 ring or 2 ring proximal, 2 ring distally. So where do you do the corticotomy, proximal or distal? Because proximal is the soft tissue is bad. Whether the foot ring is needed or not. When do you do the corticotomy? These are the questions you have to think when you do such cases. So here I debrided thoroughly, and the bond cement spacer was applied. 2 ring proximally and 2 ring distally was applied, and you can see the bond cement spacer there with a caviar there. So this bond defect was extending up to, so you can see the bond defect up or extending up to the proximal metaphyseal area, and the soft tissue was bad. So I decided to do the corticotomy down, so transport from down to upwards. So that was the plan I did. And you can see that after the transport upwards, once this reaches, then dock it there, did bond grafting. Then the remaining LLD was corrected with the lengthening. This is the final X-ray after union, where you can see. So it was total 8-month duration, well united. You can see the wound was healed by the vac dressing and SSC. So the principle followed is the same thing. The biology is improved, stability is by the spanning. And here, since bad soft tissue was proximally, corticotomy done one distally, and transport through the induced membrane upward direction. So, and usually we can have to expect equinus contraction when you transport from downward to upward. So better to really do a vigorous physio in such cases. So these are the principle I followed here. I think we'll stop here, or one more case we've done this.
Already time, I think so.
Yeah, so I will stop here. Okay, thank you very much. Sir.
Thank you, Jeejesh sir, for sharing the complex cases you have done. Sir, we have can we have a question and answer session? Then the message is there is one doubt asked by Dr. Soumya Mohapatra.
Some cases where the bone is exposed. So is Soumya Mohapatra is written when there is bone is exposed, one cortex is viable and other cortex is exposed part, where you can no need to remove the entire bone, because when there is soft tissue attachment is there, you can have revascularize that fragment. So only the exposed where the necrotic bone area, wherever you want, it is blackish, or there you can remove. Otherwise, you can keep it. In the one case I showed is that butterfly fragment was looking avascular in the X-ray, but since there is a soft tissue attachment, I kept it there, but and again it vascularized with the other bone. Vasudevan sir, what is your opinion?
It all depends upon whether you have a with a tibia. If you have a fibula there, possibly, and you have one cortex and two corners, then you can think about it. Sometimes you have a 3 corners and one full side you can exercise, no problem. You have anterior cortex, posterior medial and posterolateral, corners intact, 2 walls there, 1 wall you can completely remove it. Usually in such cases, the medial cortex or the tibia can get necrosed because that's it, there is no blood supply. Posteriorly and lateral walls are usually intact. And especially when the fibula is also there, I usually retain it, and that's more than enough.
Okay.
If the fibula is not there, then I tend to remove it.
Okay.
Eventually, surface area and contact should be good. If it's not good, one may have to opt for bone graft in such scenario.
Yeah.
Yes.
Otherwise,
but for bone grafting, the skin should be good.
yes. So, even if such fracture unites, there are chances of refracture if overall surface area is not good.
Yeah. So if you are keeping it, then you need a flap.
Yes.
The flap is required for bone grafting.
Yes.
Usually we go for flap when you need to open that area again. Otherwise, a scar is also okay.
Okay.
We have one more doubt in the message. Doubt is, do you use antibiotics for cement, antibiotic cement spacer routinely?
So those cases where the bone defect is there with infection, definitely I will use to do with a radical debridement followed by spacer. And I will wait for ESR-CRP to get down. Then only I will do the next step.
My question.
Cases intramedullary, suppose there is an intramedullary infection is there, so better to use antibiotic coated intramedullary nail. Then once infection control, you can go for the definitive fixation, either by laser or any other method.
Personally, I'm against all the cements. I don't think the cement is giving any purpose. It's a part of conventional treatment. You are going to give a dead space obliterations and block it. Generally, in Illusorol, that dead space is not a problem. Even if it is an infected intramedullary nail, I'll just ream it out, and we have a special, the bottle brush-like thing. I clean everything, ream it up, and put a continuous drain in the intramedullary area, and keep it for nearly about 6 days to 2 weeks, sometimes. And usually that is more than enough. So I have seen people putting nail and remove it. It's all very costly. When you do the cement there, many times when you remove it, the cement will stay there. It will all create trouble. So in my experience, I don't think it is really needed. But the only thing is, in the infected intramedullary nail, they are not a good candidate for corticotomies. You have to wait for a little longer time to do the corticotomy.
Corticotomy.
Yeah. Even if you put the cement nail again, the same issue comes there.
Sir, unless you
there's a stimulant again, some people use the stimulant. So I think even the antibiotic, we do a good debridement, you don't need much of antibiotic.
Yes.
The local antibiotic delivery systems and all. So you know how much is the cost of a stimulant? I think many of my patients cannot afford that much.
It's around 30,000.
Yeah.
Exactly.
So debridement is the answer for the infection, control of infection.
Yeah, I would like to remove 1 more inch bone than doing a stimulant.
Correct.
Yes, sir. Even I agree with Vasu, sir. Instead of applying stimulant, only when we are applying a plate or nail, it's good for internal fixation. But for Illusorol, a good debridement is enough.
I want to ask one question. Do you follow the same protocol of distraction when you're doing a trifocal corticotomy, or you keep a difference of half in the proximal one and one full circle in the distal one?
Me. Yeah, I always go at a slow pace.
Yeah.
Even in most of my irregular cases, I do lengthening corticotomy 0.75 millimeter per day. I don't do 1 mm per day because see, most of these cases are already inserted. So many times operated, and most of the bones is fed up with itself, all the treatments. I would like to do a slow procedure and revise the growth rate after 3 weeks. If you want to increase the speed, you can increase the speed at that time. Otherwise, I go at a slow pace.
നാളെ ഞാൻ കണ്ടോളാം.
Sir,
ഞാൻ രാവിലെ ഞാൻ ഉറങ്ങി.
a question for Vasudevan, sir.
Please,
സന്ധ്യ ഒന്നും മിണ്ടാതിരിക്കുക.
Dr. Pradeep, please mute yourself.
നിനക്ക് പോണ മുമ്പ് നിങ്ങൾക്ക്
Unmute.
Pradeep, please unmute.
Hello.
Yeah.
Sir, I have a question for Vasudevan, sir.
Yeah.
In one of cases of segmental tibia fracture where AC non-linear you have shown, where you decided to retain that fragment, means how to decide that intervening fragment is vascular or not? It is based on your clinical judgment or any other investigation you have relied on?
No, it's a gut feeling,
Gut feeling.
Amar.
Yes,
So you see the patient and see that the sinus is not that bad. It's not discharging very frequently. His clinical parameters are okay, high, not very high ESR, and CRP is also not very high. Patient is not having any systemic reactions, and overall you have the gut feeling from the experience. No?
Yes, sir.
It is mainly that. I don't depend upon your CT angio and all.
Yes.
To confirm that. And see, all these cases are more than nearly 2 years old and all, no? I don't think that bone is going, with necrotic bone, that will come out on its own by 2 years' time.
So by this time, it would surely have created problem if it would have been an avascular bone.
Yeah.
Yes. Yes, sir. And a question for Cherian, sir, that a closed injury which got complicated, in that you had used a 3 ring and 17 centimeter bone gap. Do not prefer to apply a foot ring in such cases? Dr. Cherian, sir.
I think so, sir.
Cherian sir is there.
In all transport, I think, Amar, we must put a foot frame.
Yes, sir. Yes.
So when you do a transport, you are disturbing the soft tissue a lot. And most of the soft tissue in the leg is controlling the foot. The foot may behave some abnormal behavior there. It can have some contractures, that sort of things. Better to always stabilize the foot till your transport is complete. I usually remove the frame after completion of the transport in 6 weeks. 6 weeks after completion.
6 weeks after docking.
Yeah.
Yes.
Good evening, sir. So one question about the A2 type, where you would compress it first. So you would compress it till it's in contact, and then you would maintain it for some time, and then only start distraction.
Yeah, for 3 weeks.
Okay. At that time, you will encourage the weight bearing.
Yeah, I compress it. The problem is how much to compress. It's a big question.
Yes.
So there are actually 3 parameters. One is you measure the gap from the X-ray. But that again is not right always.
Right.
X-ray is only a shadow. The next thing is you compress till the patient complains pain. He will have pain. So that means the bones are in contact. Okay. Or you see the instrument is bending.
Okay.
The screw or wire will bend. So that is the level of compression you must do. And retain in that position for about 3 weeks. By that, what I mean is a lax non-union becomes a stiff non-union. Type 2 becomes type 1.
Right.
Then you can start distracting it. But that distraction rate should be 0.25 millimeter morning and evening.
Okay.
Not like your normal transport. And you can assess the regen rate in 3 weeks time, and then you can increase it or reduce it.
Okay.
Okay.
Hello, sir.
Ali.
Yeah, sir.
Ali
Actually,
and Sandeep together.
yeah, sir, we are together, sir.
Yeah, good.
Sir,
Nice
I
meeting
have
you.
one question, sir.
Yeah.
Sir, if you said that after 3 weeks you can continue distraction at the rate of 0.5 mm per day, or
Yeah.
you can reduce it. You can reduce it. How much you can reduce it, sir?
Reduce it means?
Distraction, at the rate of distraction.
The lowest distraction point 0.25 millimeters. Two
The
times.
lowest limit is
That is there.
0.25.
0.25 morning and evening.
Okay, sir. Okay, sir. Got it, sir.
Yeah.
Thank you, sir.
How are you?
We are fine, sir.
Yeah, nice
to see you, sir.
You both.
Yeah, sir. We
All
are
the best.
together.
All the
Yes,
best.
sir. Thank you, sir.
Together is more stronger. 1 plus 1
Yes,
is
sir.
5.
Yes, sir.
1 plus 1 is not 2, 1 plus 1 is 5.
Yes, sir. We need your blessing, sir.
Yes.
Thank you, sir.
Good.
Thank you, sir.
Good evening, sir. I have a question. Sir, in the cases of stiff non-union with deformity, you distract it for union. So, do you chip the non-union, hypertrophic non-union area, or just you, without chipping, you do only distraction?
No, if it is a stiff non-union type 1, that you have very, very minimal movements and you are not getting full correction with that and it's painful. That means your periosteum is already healed.
Yes.
The bone is not consolidated. So that will work like a corticotomy for you. You don't need to do any chipping.
Okay.
But that will behave like a corticotomy. But not like you lengthen about 10 centimeters and all.
Yes.
It will allow you to correct slowly and that will heal.
And the rate of distraction, sir, it's like same 0.75 or 0.25.
Yeah, maximum is 0.75. The other
Okay.
one is 0.5. But there, it's an angular correction.
Yes.
So you have to use the rule of similar triangle.
Yes, yes.
Or a hinge. Just an opening hinge. So you calculate based on that.
Okay. Okay, sir. Thank you.
One question from Dr. Jeejesh. Dr. Jeejesh showed the last case where we had thin tibia because of thin cortex, and you planned for bone graft. Normally, what we have seen that if you just wait and allow the patient to mobilize, and it grows very well, the hypertrophy with mobilization only. And you don't need a graft in such cases when you apply an Elizero. So that is my thing, sir. What is your take, Vasu sir? What do you say about that, sir? When the regenerate is thin and do you need to put a graft or just mobilization is enough? I feel mobilization is enough in these cases. The last case of Dr. Jeejesh.
I think he's having a good amount of cortex there.
Yes, sir.
He just put a bone cement there. After removal of cement, he was seeing good amount of, I think the AP and lateral, more than 50% of the size of the bone was there.
So that's why, sir, I didn't do the grafting because I found it was getting hypertrophied. So I actually planned
Actually, not hypertrophy. There was a periosteum around that area. The periosteum started forming.
Forming the bone.
Yeah, some bone there. Hypertrophy will take much more longer time.
Right.
Sir, what are the antibiotics you use in bone cement?
Bone cement depends on usually vancomycin or tobramycin. In the
Vancomycin or tobramycin?
Tobramycin, because the thermostable antibiotic only you can use with the bone cement. If it is
Yeah,
stimulant, you
this
can use any after doing the culture and sensory find out the antibody.
yeah,
Okay.
sir.
So
Continue.
there you can use this any antibody with a stimulant because there's a setting time will be different. But most of the time in the antibody semen, you can use only thermostable antibody like vancomycin, topramycin.
Okay,
Or
sir. Thank you, sir.
gentamicin,
Ali, when you use
etc.
a cement, we have to do one more surgery for cement removal and bone grafting.
Yeah, sir. Agree, sir. Agree, sir. Thank you, sir.
Thank you.
And sir, please keep on teaching like this way on monthly basis. We are ready to.
You can all learn yourself, man. That's how we all did.
No,
Because
sir.
nowadays,
You.
we don't get simple cases. You are getting complicated cases. Straightforward case, I think, I don't remember shortly now because you have latest in treatment available. You have latest in non-onions also there.
Yeah, sir. Everybody is doing plating and nailing, and we are getting the infected cases and
More and
division
more
cases
difficult
only.
cases are now coming. You don't
Yes,
get
sir.
the old cases
I agree, sir.
anymore.
Yes, sir.
What about Jayant? The cases, the complexity is increased.
Yeah.
Because our road is widened now. 6 lane.
No, it's the smallest of PHCs also, they are doing interlock nail in all compound fractures. Even if it is grade 3A, 3B, they are putting a nail and then they land up to us.
And most of them, when they have a complication, they are covering it up. And they will come to you only when they blast.
Yeah.
Correct.
And then Ayushman is helping us come with that Ayushman scheme. So, Amar.
Yes, sir.
The discussions.
Balaji.
Any other questions from?
You have something to say?
Dilip has written one stimulant cost 10,000. It is Sri Chitra Institute of Trivandrum has developed. Is it?
Yes, sir. Recently they have developed, sir. Cost less than 10,000.
Is it available?
It's available. I'll send. It's available in the market, sir. Yes, sir. I'll send you the details.
Okay.
Bola, sir, you
Stimulant. Pardon, sir. Stimulant cost around.
Your mic is
Unmute, sir. Bola, sir, please unmute.
Your mic is mute.
Yes, sir. Thank you very much for so elaborate and extensive knowledge which you have given, sir. And just two things I like to share. One thing is now more and more such kind of non-union, especially infected non-union, they are coming, and young surgeons they are doing. My one advice is that whenever they do the X-rays, the proximal and the distal joint of that bone must be covered, so that whenever there is beginning of any deformity in frontal or sagittal plane, then can be assessed and addressed. Most of the time, we just focus on the non-union dissection. We must focus on the adjacent proximal and distal joint. And even before surgery, we must see if there is some contracture of the knee or contracture of the ankle. That should also be covered along with. This is one thing. Second thing, I think now time has come. Whenever we initially stabilize the compound fracture, instead of using AO fixator pins, that should never be used. We must always use these kind of Pitker pins so that they can later on also be incorporated into your electrofixation. I think these are the 2 points I wanted to highlight.
That's what I mentioned about the extrafocal and intrafocal deformities of non-unions and your axis planning. If you want to plan the axis, you need to have both joints.
Yes, sir.
Exactly.
Otherwise, you cannot plan anything.
No, you have elaborately told
Yeah.
this. Just I wanted, whenever I see these kind of cases, people just focus on the bone, tibia, femur.
And regarding the other thing, like the AO pins and the other pin, I think let them use the AO pin. Where now you can put a conical pin into that hole again. Just wash it and but that will stay there, provided it's not very badly infected. If you already put a 6.5 mm pin, a 6 mm pin, and that's got infected, when you are again in trouble.
And that's right. But that can be used
Yeah.
without removing. You can incorporate into your fixation.
But that's an
if you
old pin.
initially
No,
put.
we don't want old pins.
Okay.
It need to do the many job, no, like moving, crushing, and all. It becomes old. You put a pin there which is already 6 months old. Don't try to use it again, because that old guy may not do the job well for you.
Right. I was
And
just
even,
saying,
yeah,
when
and
it
even
is
the
initial.
yeah, and even the conical pins, you have to already check it. Now, many conical pins are not as strong as we want. Some of the pins are weak. The quality, maybe it's not 316. 316 many time bends. And there's a little bit of a different types, like it should be a strong pin like orthopix.
But Pitker ones, they are good enough. I am using
Pin
for
is good,
many years.
yes. But I don't want to mention any companies.
No. What I mean to say,
Yeah.
if you take some standardized,
Yeah.
then they do well and they stay well.
That's right.
And if you have only initial period of 3 weeks, 4 weeks for
Nowadays,
stabilization frame.
one Pitker pin is costing around, I think, 600 or even 1,000 rupees. There are pins which are available for 150 rupees.
Yeah.
So those people, sometimes they'll use that pin. It looks same. But when you correct it, you will see that wire pin is bending. You do 10-degree correction, you will get only 3 degrees.
That's right.
So the 5 degree, the pin will bend.
Sir, my suggestion, please, suggestion or advice or question to Vasudevan sir and Mangal sir. Can I put a question, sir?
Yeah, please.
Sir, please centralize the implant in Ilizaro to budding Ilizaro surgeons, at least from Pitker or some good company, because most of the Delhi or Gujarat med companies are giving 100 or 150 rupees pins or even 200 rupees ring per ring. But we are not satisfied. We have done multiple hundred of cases, but we are not satisfied with them. So we are using a Pitker or good quality company. So please try to standardize in ASAMI at the level of ASAMI.
We'll work on it. Sure.
Yes, sir. Amar sir, please request is my humble request to you, sir.
Sure, sir. It's in our mind. We'll surely work on it and we'll let you know.
Yes, sir. Sure, sir.
Thank you.
ASAMI itself will start making instruments.
No, sir. No, sir. That's
Sir.
not our
No, sir. The Pitker is enough, sir, I think.
Pitker's only issue is, at the region wise, the cost is different.
Yes.
Some area is very costly, some area is not that costly. It's not the quality wise.
So, sir, we can, sir, reason why, if it is different, we can at the level of ASAMI, we can
we are
ask them to
we are working on
uniform
that issue, and we are already in
the quality. There's no doubt. That is the best.
And I hope Amar sir will do something
No,
fantastic for that.
No, we are working on it. We'll surely let you know.
Yes, sir. Surely, sir.
So, should we finish, sir?
Taran, you have something to say? Just open your mic.
Yeah, sir. Thank you, sir. Sir, can we combine that cement spacer with the stimulant?
Both are having different.
We are going to combine Mercedes with the BMW.
You can right limb to left limb and different question.
Yeah, I don't like both. I would like to have Maruti or Toyota.
Okay. Thank you, sir.
So, should we
And
finish?
thank you, Amar sir. Thank
Yeah.
you, Vasudevan sir. Thank you, Rajat sir.
Thank you,
And
Lakshmi. It's a very good webinar.
Thank you, Tandik.
Dilip.
Very interactive.
Yeah,
Sir,
Dilip and Jeejesh. The credit goes to Dilip and Jeejesh.
Of course.
mainly Jeejesh sir.
No.
Both work hard.
Yeah.
Yeah. Our secretary also, President sir also helped us for the successful conduct of this program. So I request Amos to give a vote of thanks to this program and we will finish.
I thank Vasudevan sir for his excellent and elaborate